Hello, my name is Olaminji Adeparusi. I'm going to be presenting case study 9, Dementia with Lewy Bodies. In looking at this case, Mr. Hestu was a 74-year-old man who was brought to the clinic by his wife, Mrs. Estu. Mrs. Estu noticed some symptoms such as nightmare, apathy, and stiffness. She thought that these symptoms were related to depression at the beginning, but with time, she noticed worsening of Mr. Estu's condition, continued declining in memories, avoiding activities he previously enjoyed, difficulties using household appliances, and severe decline in his physical abilities. For example, his ability to walk, as it was reported that he experienced several falls while attempts to walk. Mr. Hestu's family history revealed his mother developed dementia in her mid-70s. Mr. Hestu's medical history also showed high cholesterol, cardiovascular disease with stent, and transient ischemic attack. Although these symptoms were present, Mrs. Esther said they were not continuous, and Mr. Esther himself maintained that he felt fine. Some noteworthy symptoms include forgetfulness that has gotten progressively worse, inattentiveness, hallucinatory hallucination during the day, general apathy for activities once enjoyed, frequent falls, family history of dementia, stiff stature, shuffle walk, and tremor. And it is important to note that Mr. Estu had dementia symptoms prior to the appearance of the physical or motor symptoms such as falling, shuffle walk, and tremor. Differential diagnosis. The American Psychiatric Association stipulates the following symptoms for each disorder. For major neurocognitive disorder due to Parkinson's disease, there needs to be evidence or symptoms of Parkinson's disease prior to neurocognitive impairment. These symptoms include tremor, sleeping trouble, motor skill impairment, soft, slow voices, dizziness, fainting, shuffling gait, and depressed appearance. Onset of neurocognitive impairment must also be noted, which includes forgetfulness, inattentiveness, decline in performance of other cognitive domains. In the case of major neurocognitive disorder due to Alzheimer's disease, evidence or symptoms must include significant decline in memory, learning, and other cognitive domains, steadily progressive decline in cognition without extended plateaus. In the case of neurocognitive impairment associated with Alzheimer's disease, symptoms must include forgetfulness, inattentiveness, declines in performance of other cognitive domains in progressive but insidious. Last, for probable major neurocognitive disorder with Lewy bodies, a presence of two or more core diagnostic features precedes a true diagnosis. This includes fluctuating cognition with significant variation in attention and alertness, recurrent and vivid visual hallucination, and spontaneous characteristic of Parkinsonian onset of subsequent to neurocognitive impairment. Noteworthy symptoms also include progressive cognitive impairment, visual hallucination, especially during REM sleep, depression, and delusion. In reviewing this case study, I concluded that Mr. Hestu's diagnosis is probable major neurocognitive disorder due to Lewy bodies. Due to the fact that Mr. Hestu display marked signs and symptoms such as hallucinations, especially during sleep, significant neurocognitive impairment, and Parkinsonism symptoms such as tremor, it is extremely likely that he suffers from probable major neurocognitive disorder due to Lewy bodies. Diagnosis rationale. Neurocognitive disorder due to Lewy bodies is often misdiagnosed because of its strong similarities to Alzheimer's disease and Parkinson's disease. All three illnesses can involve the presence of Lewy bodies in the brain, and all three are characterized by the insidious progression of dementia-related symptoms. However, the key difference between this disorder is related to the progression of the disease. Alzheimer's versus neurocognitive disorder by Lewy body. According to EREMA, for Alzheimer's, most physical motor impairments, shuffling walk, flat, emotionless face appear in later stage. This is not the case with NCDLB, where physical impairments such as difficulty walking are more prevalent in early stage. Furthermore, hallucination and REM sleep disturbances are both early indicator of NCLDB, while they occur in later stage in regards to Alzheimer's. Parkinson's versus neurocognitive disorder due to Lewy bodies. According to Davis Phinney Foundation for Parkinson's, the onset of motor/physical symptoms also differentiates Parkinson's disease from NCDLB. For Parkinson's, physical symptoms such as shuffling walk and tremor appearance first, and dementia-related symptoms appear later. For NCDLB, the situation reverses. Dementia-related symptoms appear first, and motor physical symptoms known as Parkinsonism appear later. Mr. Est's condition fulfills criteria for NCDLB diagnosis. The early stages and progression of dementia occur before the manifestation of its trademark symptoms: hallucination and REM sleep disturbances, tremor/shuffle walk, and so on, which further indicates NCDLB and rules out Parkinson and Alzheimer as the primary diagnosis. Further diagnosis tools should be employed to confirm this diagnosis. According to Lepofsky, much information can be garnered from the monitoring of the progression of the disorder as much of the distinguishing feature of NCLDB appear after initial symptoms of dementia. Specialized tests such as the mini-mental state examination and the quick dementia rating scale can identify the presence of dementia and rate its severity. The Lewy body composite risk score can be especially useful to distinguish Lewy body pathology from from Alzheimer's disease. Furthermore, Mr. Est's negative reaction of Alzheimer's medication, the sleeping pills, further indicate that his condition is not simply Alzheimer's. Mr. Est's family history of dementia put him at higher risk for developing this disorder. Lastly, frequent fall is a common symptom of NCDB, which Mr. Est has. New potential diagnosis tools. There are new potential diagnosis tools being used to further determine the presence of Lewy bodies. This includes neuroimaging technologies such as MRI and PET scan. Ultimately, there needs to be more research conducted on the protein and substances associated with the formation of Lewy bodies in certain parts of the brain. Treatment options. Currently, pharmacotherapy is the most effective method in the treatment of dementia with Lewy bodies. Cholinesterase inhibitors are the first line of treatment, in conjunction with psychotherapeutic measures such as cognitive behavior therapy and talk therapy. Research showed that cholinesterase inhibitor may significantly improve cognitive functions, behavioral disturbances, activities of daily living, and global function compared with control treatment. Cholinesterase inhibitor includes donepezil, rivastigmine, and galantamine. Little research exists on the effectiveness of galantamine and rivastigmine, but in the case of donepezil, research is promising, as studies show that side effects may be minimal and efficacy widespread. Thus, donepezil stands as the best pharmacological agent for Mr. Estill's condition. In conjunction with donepezil as a pharmacological agent, Mr. Estill might benefit greatly from cognitive behavioral therapy. Treatment plan. In assessing Mr. Estill's case, I came up with a pharmacological and psychotherapeutic regimen that will include 5 mg of donepezil taken by mouth every night before bed, and an increased 10 mg dosage if symptoms persist after 4 weeks. Medication ceases if adverse effects have significant negative impact on patient's health. I also recommend cognitive behavior therapy with psychotherapists twice a week, and follow-up appointment scheduled for 4 weeks after initial visit. In conclusion, I chose to investigate case study 9 and concluded that Mr. Heston should be diagnosed with probable major neurocognitive disorder with Lewy bodies. The treatment plan for this disease may involve pharmacological agents such as cholinesterase inhibitor, as well as psychotherapeutic measures. Thank you.